This is Mutlu from Istanbul. My title is There is no simple left main distal bifurcation procedure. I will present two short cases. This is first case. There is tight stenosis in dilated ostium. Minimum lumen area is 3.4 millimeters square. FFR is 0.75. Sarcostium is clear. There is only mild disease in the sarcostium. Diameter is about 2.7 millimeter in the sarcostium. And there is all stent here, and this procedure will be simple from left main to LAD crossover, and distal end of the stent will be inside the previous stent, and there is no risk of edge dissection in the distal end, and there is no risk of compromise jailing of the sarcostium because it's clear, and we planned a simple stenting in this patient. This is a 52-year-old female, many distal additional stenting procedures for in-stent restenosis in the lady. I applied terracotta balloon 3 years ago and followed without symptoms up to last month. She has complained of effort dyspnea for the last 1 month. My plan was, after angiography, simple crossover stenting. But unfortunately, my young colleague and nurse forgot to give bolus heparin, and left main thrombosis occurred in this patient. Patient felt chest pain, and we urgently treated this patient with 2.5 balloon predilatation, and this is stent 26 millimeters drug-eluting stent. We put stent, and this is pot with 5 balloon. Our first plan was to guarantee left main. This image is after pot in the left main. You see thrombosis in the sarcostium. We were afraid of this thrombus because of risk of retrograde propagation and left main thrombosis. And there is also thrombus here in the old stent in the LAD. What's the next plan? We used 4O non-complete balloon here at low pressure. It was actually post-dilatation balloon of the new stent. And then we dilated overlapping area and ostial and proximal LAD segment. And then we put 2.5 balloon into the circumflex. We dilated circumflex and LAD accordingly, and finally made kissing ballooning. And this is final image. This is final angio from another view. There is no thrombus in the LAD and circumflex. But don't remember, simple procedure can turn into very complex intervention in left main PCI. This is second case, old angio in 2022 showed left main distal stenosis and also RC ostial stenosis, LAD ostial to proximal lesion. Sarcostium seems good. This is RC ostium. But this patient had chest pain, but it was overlooked because of sternotomy. And surgeon and cardiologist think that chest pain was resulted from other reasons, not coronary events. But at the end, there was a slight ST elevation in the inferior leads, and we made another angio. 16 months later, Lima was not functioning. There was antegrade flow in both circumflex and LAD. We were surprised. This is Lima. Lima is atrophic. And anastomosis is here in the curve area. We don't know the role of this curvature uh, in malfunctioning Lima. And this is RCA. RCA looks patent. Osteolesion is only moderate, and saphenous vein grafts become filled with thrombus. And this is another graft to the OM. It was a tiny branch, and circumflex is mainly supplied antegrade. And in very distal left main stenosis, balloon positioning for pot is not easy. But in this case, bypass graft for to circumflex was patent. We think that we do not need to be afraid of carina shift to circumflex ostium too much. And we predilated the lesion. Patient felt chest pain after predilatation. There is slow flow in both circumflex and LAD. We put stent, but after stent, it wouldn't improve, and we applied adenosine, intracoronary adenosine, and perfusion is improved suddenly, and also bradycardia and hypotension improved after the treatment of no-reflow. The next step was stent optimization. This is probably LAD ostium. This is the left main stenosis point. And we made post-dilatation, stent became bigger and seems better, but there is carina shift in the short costume. But antegrade flavor is good, and we know that saphenous vein graft to obtuse margin was patent. Then we skipped the short costume and post-dilated the LED stent. It's better. And this is final angio. We treated left main stenosis and stenosis. After the procedure, patient complained chest pain in the coronary care unit, and we checked ECG. There was marked increase in the ST segment elevation in inferior leads. But patient seemed not toxic, and there was no change in echocardiographic findings. We treated conservatively because of patent bypass graft and good antegrade flow. Cardiac symptoms improved after nitro, intravenous nitroglycerin, and analgesics. She had another problem, cholelithiasis, and she is now waiting for treatment at least 12 months for ERCP. My conclusion is there is no simple left main distal bifurcation procedure. When it comes to left main PCI, you need to be prepared for anything, and it has massive effects to hemodynamic parameters. You need to quick to treat no-reflow and anticoagulation problems because collapse may occur soon.